Lovely. Can I welcome everybody back to the second half of our afternoon? This is our question and answer session. You've had a chance to cogitate over a quiche and a profiterole about the thoughts that Brian Hughes' presentation there raised for you. Certainly a welcome to people who are watching online as well. We have a message of warm thanks and regards to you from Richard Ramsire, and there are other people watching us online as well, so welcome to them too. So this is our question and answer session. We're happy to do it by people just indicating by their hand, and I'll bring the roving mic to you so that we can capture every question and it's actually heard on the live stream, if that's okay. One of the things for me, just to start this off, is that I feel like, having been involved with the ME community for a very, very long time, that there is this conversation to be had about stress impacts on people's symptoms. And I think people experience phenomenal amounts of stress when they have this illness. It's an illness where they are constantly met with disbelief, where friends and family are trying to be supportive and helpful and encourage people to do more when they can't, where people fail to understand the acute levels of isolation that people experience, where people have an incredible uphill struggle to get any form of benefits at all, which the group is trying to support people with, where people go through extraordinary lengths to get the kind of social care that they need. And basically, if you are going to choose a stressful illness, then ME/CFS is the one to go for. It's an extremely, extremely difficult illness to live with. So what I'm really keen to do, building on what Brian's talked to us about today, is to have a real conversation about stress. Stress isn't generally considered to be the cause of ME/CFS, and in my view, the science supports it not being the cause of ME/CFS. However, everybody here and everybody in the ME community will need some support in dealing with the incredible battles they face in living with this illness. So I'm keen that we have a sensible conversation about supporting people with stress, because stress exacerbates symptoms, whereby you don't get embroiled in this conversation where people seem to think stress was the cause of your illness when it wasn't. So that's the bit I kind of want to kind of unpick. And I don't know whether that's not quite a question, it's a statement, but whether that's something you would feel like you'd like to sort of start off by commenting on, and how that can impact on local services and the support we can offer as a group.
Thank you. I think the point is very well made. The condition is extremely stressful. I mean, I've met a lot of people in different places with ME or CFS or related conditions. It is incredibly stressful. So I think there would be a few strands to that in terms of ancillary care. Stress is not an enjoyable experience, and it can precipitate clinical distress and clinical depression. And I would not be at all surprised to find that there will be a high degree of comorbidity between ME and CFS and depression. And in addition to that, there would be a knock-on physical impact too. So people who do have clinical depression are 8 times more likely to get heart disease than people who don't have clinical depression. So one thing cascades into another. So there are a whole set of problems that are then suddenly there. And I agree, you have enough to be dealing with, trying to get an adequate service provided to you, but to do that with all of this on top of you as well is incredibly difficult. You're absolutely right also to flag up the risk of the conversation getting out of control and people becoming defensive about being accused of agreeing that stress has caused my illness or that my illness is somehow psychological. So absolutely, you can navigate that. You can sort of compartmentalize that and explain and have a consensus among yourselves that this is not what we're saying. What you're saying is you have needs in terms of mental well-being and mental health care that arise from your illness, that are not causing your illness, but nonetheless need attention. And a community, it will be a good exercise for the community, I think, to review that and see what can be done. In terms of actual research, pure and simple, the idea that the stress of an illness might actually exacerbate the illness itself is quite plausible. And there are lots of illnesses that are physiological, that nobody disputes are physiological, like arthritis, that get exacerbated by stress. So it is a bad cocktail when the service provided to you is actually stressful, because it will make your illness worse rather than better. Please.
Hi, so you've spoken very succinctly about the physiological nature of stress and the way the experience of stress causes physiological changes in our body, and that is undisputed. And as a result, I'm not sure if we should discount the fact that some people who develop the syndrome might have chronic or acute stressors as a trigger. We don't know necessarily what is the causative factor for everybody. And to blanket say it's not stress maybe erases the experience of some people who have the syndrome. Stress is a very powerful physiological experience for the body, and for example, if someone's nervous system was under a state of stress for an extended period of time, which the human nervous system isn't designed to be, that causes changes, to a fundamental metabolic level. And if the body loses the ability to then reset to the normal, you're going to end up with a chronic physical condition caused by what would seem to be a psychological issue. It doesn't make it any less real, in the same way that heart disease isn't any less real if the blood pressure changes are caused by stress. So I don't know if it's necessarily helpful to blanket erase stress as a causative factor for some people. Doesn't mean that the illness is psychological.
Just by way of comparison, maybe we know that traumatic stress is particularly dangerous, and it can be difficult to pinpoint in the individual. That is just a scientific point, it's not a clinical point. So much of the research is on large groups of people who've undergone trauma at the same time, a catastrophic incident, or maybe long-range research about people who survived major terrorist attacks or major even famines in different parts of the world at different times. And you follow those people up, and not just that generation, but even the generation that follows has a decrement, has a healthcare, has a disease load. And there are lots of studies to corroborate what you're saying in general terms, that stress can precipitate illnesses, and real illnesses that are very long lasting. And in fact, if it's a community stress, if it's a social stress, it can actually go a generation ahead. If you try to translate that into the individual, it is absolutely plausible that an individual can encounter so much traumatic stress in their own life, or a persistent load of stress over a period of time that is significant, that it would have a knock-on effect on disease processes and might even trigger a disease, especially if it's combined with some other risk factor like an infection or some other irregularity or some other, as they call it, insult. So these things are there, and we have to remember we don't have a consensus as to the cause of ME and CFS, so we don't know what the triggering factors are, and for some people it could be a combination of stress with other things. And there are many diseases that lie dormant in the population that are never triggered by stress, and maybe ME, CFS could be one of them. So it is a complicated picture, absolutely, and it's important to bear in mind all the possibilities. So, I'll do the roaming.
With all the controversies and cock-ups in the ME research, where do we go forward now? Where do we go from the research to help us?
Yes. I would say that, okay, so it is a team effort, it is a community effort. It is a difficult thing for one person to intervene on to change. I think the professions need to be put under the spotlight. I think there needs to be wide understanding in the community at large as to the nature of the problem. I do think the science, the core science, is improving, and I would make the point that it isn't outsiders who are critiquing psychology like this. It is people within psychology who are critiquing psychology like this. So there is a growing movement of dissent, and some people are very, very senior people. So it's not just a kind of a bubbling under of novices. There are many leaders in psychology who are saying exactly this type of thing about psychology in general. So I wouldn't like you to think that it's a lost cause, that there are cock-ups and controversies, and they're baked in and they will never go away. The very fact that we're aware of them, it's a bit of a cliche, but the very fact that we're aware of them is the result of people being vigilant and exposing them. So I would hope that we are turning some kind of corner, and that psychology research, the quality control of psychology and healthcare research is being improved and being brought into line with other types of quality control and other types of research that we take for granted. But how does an individual take action to help this along? It's hard to translate it down to individual action. I think there are a few approaches that might be taken. There would be other disease groups, other illness groups, other populations who are having similar experiences. One observation I would have, I have direct personal involvement in another disease group through my family. And I understand that there is a whole world of people there who think that their problems are unique to them. But many of the challenges they have in accessing appropriate services and tackling naivety on frontline service delivery and dealing with, a lack of awareness as to the quality of the evidence and so on. A lot of that is reminiscent of what we see here. So I would suggest that there may be some synergies in collaborating with other patient groups. Because if everybody is finding the same thing, then there's a greater chance that the problem will be believed, if you want to put it that way, by the wider population. Because at the moment, you're your own eyewitness testimony. You need to have corroboration and collaboration perhaps. So I would say it has to be consumer-led, or it doesn't have to be isolated to consumers, but I think what you can do is going to be consumer-led. But it might be an opportunity to look across other similar groups to see what the experiences are, because I would suggest that this problem is not confined to NACFS. I think the professions then have to get their house in order as well, because professionals are responsible for their own affairs. Some people will say that the bad habits are built into things like universities, how universities are ranked, how they are funded, how research is measured, how research quality is assessed. A lot of that is accused of perpetuating bad research practices. So that could be looked at. But these are, I accept, are challenges. They're not top of people's lists when they go and vote for new governments. So it's hard for the ordinary citizen to change the system. But I think awareness raising has to be done, because for many people that's all they can do. But I think it's very powerful. So beyond that, I mean, we could talk for hours on this, I'm afraid. I hope that those few thoughts are helpful.
Just following on from that, I wrote down a phrase from your conclusion, which was, patients must become assertive and informed consumers. I just wondered if you had any recommendations as to how someone like Sheffield and Fibromyalgia Group would support people to do that.
Yes, and I in no way intend that to be patronising, because I know you appreciate you need to be assertive consumers. I suppose there's a kind of a psychology of that too. And in any kind of activism, there is a need not just to state your case or to be clear in your own mind what your case is, but to find ways of communicating that to key stakeholders, and maybe even consulting as how best to do that. And I mean, some of it comes down to hiring lobbyists or getting PR advice or getting your message out there to the general public in a way that is digestible to the general public. And that creates pressure to pursue any cause. This is activism. Too many activists get kind of caught up in their own discussions among themselves and taking positions that are nuanced and different to their fellow activists. But this is ultimately a selling exercise. You have to sell your message. So being assertive consumers doesn't mean going in and saying, I don't believe you. It means being able to say that I'm aware that this is controversial, and if you want further information, here is a document, here is a website, here is a referenced source to tell you what I mean. Not every patient is going to be conversant in the technical language, but every patient can say, no, I am aware that this is a problem, and here are the details, and people better trained than me can explain them to you. And I again make the comparison with a product on the shelf of the supermarket. If it contains a contaminant that is dangerous to the public, you would expect it to be taken off the shelf. You don't have to be a physicist or a chemical scientist to be able to complain that this product is available. You just need to be able to say, I know this is a dangerous product, it needs to be taken away, and here is the information. So a group like this can collaborate, can curate that information, can generate that information, and can make it available to new patients who join the community and to existing patients who can then take it forward. I do think a lot of groups succeed in accessing services for their disease or their illness condition. Some groups are very successful at that because a person receives a diagnosis with condition X, and then suddenly they can access the association, and they will be presented with all sorts of documents and flyers and guides and explainers, and they bring them then with them everywhere they go. So that methodology is out there for other conditions. So something along those lines need to be pursued. But I realise it's I don't want to in any way kind of reduce it down to simple solutions. I mean, unfortunately, I'm much better at identifying the problems than fixing them. But you know, as the cliche goes, you first have to accept you have a problem. So I'm helping with that at the first step. Sorry, you wanted to come in.
A little expansion. I think there is a misconception, particularly amongst the tabula press, as we saw, assuming scientific illiteracy amongst the patient community, which is insulting, frankly. I mean, apart from the fact that we all have to become our own best advocates, most of us, you know, had educations and jobs before we became ill. But not all of us do have scientific training. How helpful do you think it might be to kind of increase scientific education within patient communities about things like experimental design and research criticism?
I think that's I think that is a good point at both levels. One is, and I always try to tell students this, is that when you're explaining science or psychology to non-specialists, that doesn't include, you shouldn't visualize people as somehow ignorant. These are often people who are specialists in other areas. And likewise, when you interact with a client in a psychological context, that person is going to be expert in their field, whatever that may be. And more people, and that might be a formally trained educational field, or it might be some other field, but they will likely be capable individuals, exactly like you described, and people can understand the science, and increasing numbers of people just on a simple level are scientifically educated to some degree. Secondly, I agree with the point that it's not just the subject matter, it's also the method. So it's not just the disease and the disease features and the treatments and all of the particulars relating to how treatments are delivered. Absolutely, there is great benefit to being aware of how the research evidence is generated. So a basic understanding of how research is done, what separates good research from bad research. It's actually of wide applicability. It's of great usefulness to the wide public as well as to particular groups like yourselves. I would recommend that actually, yes. What makes a clinical trial? And not just, what do they look like, but why is it like that? What are the safeguards? What are they for? And what happens if they're not there? I think people are naturally curious about this anyway. I mean, for years and years and years, people have been curious about consumer awareness issues and scandals about products that are dangerous that are being on the shelves like we discussed. People, the ordinary citizen has an interest in knowing these things and will be happy to know them. So I don't think you should be shy about making sure that it's part of your messaging. We had a conversation outside, and these issues can be very wide, and there is a great societal need for fact-checking. And it's in the air. It's a modern concept, even though it's also an ancient one. But the term fact-checking is coming up again and again and again. And if you look at political issues, it's all about, I don't believe that, or I do believe that, or this is an unreliable claim, or this is isn't fact-based. That discourse is emerging, and I think what we're seeing is more and more people are interested in having the facts, and therefore more and more people are interested in you not having them, because people are threatened by facts. And a lot of the noise you hear about fake news and all this stuff, a lot of that noise is people pushing back because you're getting too many facts, and we want to go back to the old days when only some people had the facts. So I think if you keep getting that out there, it is always going to be useful, and not just for the immediate political cause or advocacy cause that you're pursuing.
Okay.
I wanted to say just one other thing, incidentally. I alluded to a little bit earlier about not all psychologists. That sounds like special pleading. It sounds like but it is true that psychology is a wide-ranging science, and a lot of this is useful and applicable to all sorts of ways. But it is psychologists looking at how psychologists behave. It's sort of like psychologists under the microscope, and it is psychologists themselves who are revealing this. I'm not in favour of professions policing themselves. I'm not in favour of professions peer reviewing their own efforts. I think all that is bad. But I think that is bad because I know psychology. I know that people are prone to this. And so it's important that we're aware of that. It's also important that not all of the people in the PACE trial, for example, are psychologists. Many of them are, but some of them are psychiatrists. And there's a whole range of issues regarding medical hierarchies. I mean, the world of professional medicine is as hierarchical as any feudal society. It's all about who you know and going up and down and social climbing. And it's very damaging. But it's a bit about how people behave and feel and think in those situations. It is psychologically interesting. But it's not all psychologists' fault. Okay? It's some of the people involved are psychologists and nothing else, and it is their fault. But other people are also involved. And I would end with a note of optimism that there is an appetite for fixing this within the psychology profession, and that isn't you. So be part of it, and be part of this kind of revolution, and we will make this better in time. Thank you.
Thank you very much, Professor Hughes. I would just like to pick up on a couple of points made. In terms of having a well-informed ME community, we have a website that we've redesigned this year. We would love to put on more and more and more kind of factually correct, scientifically based information and advice and guidance for people. If anybody in this room would like to help produce some of that content, we always welcome input. We welcome input to our magazine as well, if anybody would like to write any scientific articles. We did float the idea of running a science club, but we haven't had takers for that at this point in time. It's quite an exhausting thing to do, I think, to have it as a kind of science reading club. But we would certainly be very much up for supporting that if there was interest. echoing your kind of ending on a positive note as well. Earlier this year in January, I think, we did have 27 MPs in Parliament all calling for an increase in biomedical research for ME/CFS, and there was a similar call for fibromyalgia as well. There is interest at a national level. There is interest amongst some of the major organisations. As we know, anything agreed by Parliament doesn't mean to say it actually happens. So we've obviously got to do the next stage, which is follow that through, because it's not yet government policy to act in that sort of way. And just to remind people about Millions Missing, which is an action that we do in Sheffield every year as part of 130 cities around the world, where we make ME visible out on the streets, and we'll be doing that again next year, which happens to be the 200th anniversary of the death, I think, of Florence Nightingale, who is reputed to have had ME. So, and Florence Nightingale has a Sheffield link because her parents were born nearby. So we will be doing something about that. I don't know what yet, but if you'd like to get involved, please do. So, yes, so I would like to say an enormous thank you to everybody for coming today. Thank you to all the trustees and everybody who's helped. Thank you to Carol for organising our guest speaker.